Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I'm Sarah Repking, nurse practitioner at Rush University Medical Center and an associate editor with CLD. I'm here with Dr. Sasha Deutsch-Link, transplant hepatology fellow at the University of North Carolina, and the author of Ascitic fluid cell count should be routinely sent with every therapeutic paracentesis to assess for spontaneous bacterial peritonitis, which will be published in CLD. Dr. Deutsch-Link, thank you for joining us today.
Thank you for having me.
So I'd like to ask you a couple questions about this great article. First, can you briefly summarize why we should be setting cell counts on routine outpatient therapeutic paracenteses?
Yes, so we know based on a meta-analysis published in the European Journal of Gastroenterology and Hepatology in 2021 that the prevalence of SBP in patients getting routine outpatient therapeutic paracenteses is around 2%. So that's 1 in 50 patients. It's a similar annual incidence to HCC in some of our patients with cirrhosis, depending on the etiology of disease. Additionally, SBP is challenging to diagnose clinically. Many patients are asymptomatic, particularly early in the disease course, which is why it is recommended that all patients with decompensated cirrhosis and ascites who are hospitalized get a diagnostic paracentesis. We also know that cell count has excellent sensitivity and specificity for diagnosing SBP. Sending routine cell counts on therapeutic paracenteses allow us to diagnose and treat SBP earlier in our patients. And we know the complications of SBP can be quite devastating for our patients. If we can diagnose and treat SBP earlier, we can improve outcomes. What I'd also like to add is that this applies to patients with cirrhosis who want life-prolonging care. This does not apply to our patients with malignant ascites or those who are pursuing comfort-oriented care only or hospice.
And can you comment on the cost associated with this approach you're discussing?
Yeah, I mean, this can definitely be an initial concern with sending routine cell counts on every patient getting therapeutic paracenteses. However, according to the Centers for Medicare and Medicaid Services, the cost of a cell count is only $5.60. This may be slightly higher in patients with private insurance, but this is not exorbitantly expensive. And we should note that the ticket price on cell counts for people who are uninsured or underinsured or who are self-pay do not reflect what insurance companies or patients actually end up paying. The true cost is probably close to what the Centers for Medicare and Medicaid Services quotes, which is about $5.60. We do know, however, that hospitalizations and ICU stays are extremely expensive. There was a paper that showed that the average cost of one hospital day for a patient with chronic liver disease is around $2,600. So that's the equivalent of sending 465 cell counts. And so if we can even reduce hospital stays for SBP by 1 day in our patients or prevent an ICU stay, it could potentially be cost effective to send these routinely. It should be noted, however, cost effectiveness of this approach has not been studied, and so we can't comment on whether it's truly cost effective, though there is a possibility it actually could save money.
And what about SBP prophylaxis? In your job, don't you see a lot of these people are already protected with prophy, or are they usually not?
Yeah, I mean, ideally, yes. And I think there's wide variability in practice settings, but there have been a few retrospective studies that have examined real-world practice on SBP prophylaxis. And they found that around 70% of patients who meet criteria for SBP prophylaxis may not receive it. And I know this may be quite variable depending on what access patients have to tertiary level care for their liver disease. But this is important because more than half of patients who meet criteria for SBP prophylaxis but don't receive it will get SBP within 1 year. So it's a really high number. So as such, many patients receiving these regular routine therapeutic paracentesis are at high risk of SBP and may not be prophylaxed.
Oh, over half. That's quite a huge number. And are you able to describe a clinical scenario where the approach you're discussing could really be helpful?
Yeah, absolutely. So I like to kind of think of a patient that I once took care of, but imagine one of your patients has diuretic refractory ascites and otherwise pretty normal labs, low MELD, but they're undergoing routine serial therapeutic paracenteses for the management of their ascites. One day you obtain labs the same day that they're getting their therapeutic paracentesis, and all of a sudden they have a severe acute kidney injury. And then you send them to the ER for further evaluation and management, concern for HRS. And there's no fluid pocket to safely perform a diagnostic paracentesis in that patient because you just completely drained them. So what do we do with this patient that's in the ER that you can't sample their ascites fluid? Do we assume they could have SBP and empirically treat? Do we wait until the fluid reaccumulates and then perform a diagnostic paracentesis, potentially delaying treatment for SBP, which can worsen outcomes? And there's actually even been studies showing that delaying diagnostic paracentesis on patients who are hospitalized is associated with increased mortality. So this is really a scenario where you would have really wanted that $5.60 cell count.
Dr. Deutsch-Link, thank you so much for your time today on this extremely interesting and relevant topic. And thank you again for joining us on another installment of the Clinical Liver Disease video series. And thank you, all of you out there, on behalf of us on the CLD team for joining us. I hope you found this information on diagnostic paracentesis to assess for SBP interesting. And for more information about acidic fluid cell counts should be routinely sent with every therapeutic paracentesis to assess for spontaneous bacterial peritonitis. Please visit us at www.cldlearning.com. And thank you again for watching.